Hello, everyone. Again, my name is Isaac, and I'm here today to present on the Empower Peer Support Initiative. I am very humbled, grateful, and slightly nervous to be in front of you all, but I am very proud to say that we have completed our systematic review, which was distilling the active ingredients of peer support interventions, specifically looking at evidence-based trials for individuals living with serious mental health conditions. So, to write a brief introduction, I didn't want to spend a ton of time, but just providing a brief overview of the fact that I need to lecture you all about the current global mental health crisis that we've been facing for the last couple of decades. But wanted to point out that peer support is one of the many models of care that has been born out of that global mental health crisis, and that peer support is unique in its ability and its origins in political resistance and really a reaction from underrepresented communities to find support amongst each other. And in the last couple of decades, it has become a more formally adopted practice in which Empower Peer Support itself is seeking to further formalize. So first wanting to begin by coming with a common definition of what exactly is peer support. And I want us to preface that you will hear peer support referred to in a lot of different ways. You may hear it as a peer coach, a peer support specialist, peer support worker, but at the end of the day, it is all referring to the same thing, which is essentially an individual who they themselves have undergone recovery and experiencing what does a particular mental health condition feel like. What does recovery look like? And recovery doesn't always refer to clinical recovery. It can refer to non-clinical or less formal models of care. And the actual support that manifests out of peer support comes in a variety of ways, including these 5 here, which I wanted to briefly go over. Recovery planning is one of the most common methods we see for peer support, in which the peer supporter generally is supporting developing mutually established goals and working with the peer they are supporting to identify those goals, identify steps and resources necessary to achieve them, and potentially revise that plan as they are undergoing recovery itself. As I mentioned earlier, resource sharing is another component of that, where the peer supporter works with the peer they are supporting to identify resources, both clinical and non-clinical, and it can even be in practical help, such as the peer supporter accompanying the peer they are supporting to an appointment, helping make that appointment, literally helping provide transportation to get there. And so there is a lot of practical help with that resource sharing. With the other 3 icons you see here, these are a lot of the values that are rooted in peer support, in which it is not focused on the symptomology necessarily, but is really rooted in what is the peer's strengths, where can they focus on to continue growing to enhance their recovery. And peer support highly emphasizes mutuality and the sentiment that since the peer themselves have undergone recovery, there's a deconstruction of power dynamics because they too have experienced the stigma associated with, let's say, diagnosis, or even trying to find support in the first place. And ultimately, peer support is an empowering model as it ultimately provides agency to the peer, where the peer is empowered to say, I don't want to do this as part of my recovery journey, I'd rather do this, rather than listening to a traditional model where they may be prescribed medication or prescribed a solution. So really it is peer-centered and peer-oriented when developing that plan. I want to go into the landscape of what peer support looks like, first in terms of the literature and then the national landscape. So beginning with the literature, there is a growing body of evidence that peer support ultimately does work. Peer support across the literature has shown that peer support interventions result in increases in outcomes such as self-esteem, sense of control, hope, empowerment, empathy, etc., and that it has the ability to decrease psychotic symptoms, substance use and depression, as well as hospital admission rates, showing in the literature that there continues to be growing evidence that peer support trials do work. In regards to the national landscape, before I go into the overall landscape and what it looks like on the federal level, I want to bring attention to these 4 documents. As you can see, the earliest formal federal guidelines that were published was in 2019. So just within the last 5 years, we have seen in the United States the formalization of peer support. And that really is spoken to just how inconsistent has been implemented as I go into those details. To go over what each document is briefly, in 2019, SAMHSA, the Substance Abuse and Mental Health Services Agency, which is the primary regulatory body on the federal government for peer support, first published the core competencies for peer workers. And this is something I'll refer to consistently throughout our study today. But this was essentially the first federal standardization of what content should peer support workers be trained in. In 2019, the National Association of Peer Supporters, which is a nationwide nonprofit that represents the peer support workforce, published peer specialist and supervisor guidelines, which provided formal recommendations for supervision practice. In 2022, SAMHSA published the National Model Standards, which provided guidelines and regulations around what do training bodies need to include in their interventions in order to formally certify peer support workers to become service delivery agents in the US. And most recently, in collaboration with SAMHSA, the Peer Recovery Center of Excellence just last year conducted a state-by-state landscape analysis of what does early implementation of peer support look like across the United States. In regards to the federal standards, these are the recommendations that have been outlined in regards to training and certification as well as supervision. This is a summary of 3 of the documents I had previously described, in which, just to provide a quick summary, generally training, they require and suggest that training occur between 40 to 60 hours, and also recommend a formal written examination. And they really emphasize that the examination should focus on the training content areas rather than competency in areas that, although potentially measured in other traditional clinical settings when providing mental health support, may not necessarily be relevant to the peer support role. In regards to work experience, they suggest a maximum of 120 hours of supervised work experience and a minimum of 0 hours to accepting any combination of volunteer and paid work. In regards to cost and fees, across all documents and all issue briefs, there is a consistent emphasis that there should be no financial costs associated with training. In regards to the actual implementation, they do recognize that there is a role from the states and from the counties to provide subsidies in the case where costs are unavoidable to alleviate that financial burden off of those seeking training and certification. In regards to supervision guidelines, the only national regulation that has come out in the last 5 years was that NAPS document. And in that document, which if you have time, I highly encourage you all read through it, but there are generally 3 trends in these 12 recommendations they provide, which is 1, the emphasis that the person who supervises peers should also be a peer themselves. So they really emphasize those who are developing these trainings develop supervisors in peers so that they are able to recognize what the peer support worker role is and how does it distinguish itself from other traditional provider roles. There's a heavy emphasis on developing a code of ethics and really establishing what are the boundaries of the peer, what happens if there's a violation of that, and how can we provide support to the peer supporters and the organizations implementing peer support so that they know how to address any other concerns. And overall, there is consistent emphasis on values such as hope, empathy, respect, and open-mindedness. And the general concern that consistently persists throughout all of the literature, which I'll talk about more later, is this emphasis on the deconstruction of power dynamics and how peer support, again, really needs to be this mutual practice, and that includes a new vision of supervision. All of the statistics you see here is a brief summary of the Peer Recovery Center of Excellence's landscape analysis that was conducted in 2023. I will not go into super great detail about the specifics, but to describe a couple of trends, what we have seen since last year is in regards to the implementation, in which in their landscape analysis, they included 55 studies. The reason it's more than 50, and I know there's only 50 states, is that some states, such as California, where I got trained, is on a county by county basis. And so there are multiple official training entities in certain states. So they included 55 trials in their landscape analysis. And of that, they found that a little over 3/4 required formal examination in their training. A little more than half of all trainings did require supervised work experience. And generally in actual implementation, that requirement was between 200 hours and 1,000 hours. And the most common time of a training program was 40 hours. In regards to the cost and financial burden associated with both training and certification, you can see the graphs here on the bottom. As you can see in training costs, most frequently, about 1/3 of all programs evaluated do have no cost associated. I want to emphasize in the reporting of free, they did collapse and include both government subsidized programs, meaning there is a cost, but the government has subsidized it, or there was essentially no cost. And as you can see for the varies by category, many states who are on a county by county basis, there is variety in access where some counties have a cost associated with accessing the training, whereas other counties have free training. So you even see on a local level, there are varieties in the financial burden associated with receiving training, depending on where in a state you live. In regards to certification, a vast majority of trainings did not provide information to determine if there's a cost associated with certification, and the second most commonly reported was there was no cost associated with certification. For the 9 studies or for the 9 training programs that they did assess that had a cost associated, the price rate of certification, which usually this is your application fee and your licensing fee, was around $101 to $150. And I also want to emphasize here, and really through this image comes from one of our project partners, the Global Mental Health Peer Network. And I want to emphasize that the United States is not unique in its implementation of peer support. And there are many other national contexts where peer support has been adopted much earlier than our own national context. Through the Global Mental Health Peer Network alone, they have 47 different countries that they represent and in that network, there are formal peer support workers doing on-the-ground peer support work from across 47 countries. While there has been a significant improvement in the implementation of peer support, and we continue to see in the landscape formal adoption of this method of care, there are significant challenges to expanding the peer workforce, primarily these 4. One of the most prevalent barriers that we see in the implementation of peer support is a clear lack of role clarity. Peer drift is a common concern brought up by peer support workers, where despite being trained in peer support, many organizations who are hiring these workers are asking them to complete responsibilities that are not within their initial scope of training. And so that tends to result in either people leaving the peer workforce or general low job satisfaction. As you saw in the national landscape data, there is also inconsistency in training. As you will see in our own systematic review, there is great ambiguity in the way training content is reported, and there is little mechanisms to assure the quality of training that, let's say, for example, in my own home state of California, what makes a training in one county better than the other, and why is they so vastly different in the content when it has the similar state level infrastructure. And then the other 2 additional barriers that come up frequently is that stigma and power dynamics are very common, especially in traditional medical systems, where non-peer staff or those who may lack peer experience may hold negative attitudes towards those with a condition, or may doubt the capacity for a peer support worker to deliver care. Because the most question that often comes up is, how can you deliver care if you are also still recovering? What happens if you're re-traumatized? And these are questions that do come up for peer support workers in my conversations when they have entered the workforce. And lastly, systemic barriers, where both on a national funding level and a state-by-state funding level, there are significant financial barriers to alleviating that financial burden, as well as to develop even more peer support programs for community specialized care. So this systematic review was born out of recognizing that inconsistency and wanting to evaluate what does ensure a quality peer support training program. And so for our systematic review, we had 3 primary questions, which was 1, what are the key elements of peer support interventions? 2, what competencies and trainings are required for peer support workers in these interventions that are targeting those with SMI? And lastly, what is the evidence for the feasibility and acceptability of those interventions? So to begin with our inclusion and exclusion criteria, we only looked at evidence-based randomized controlled trials that measured peer support interventions. For our population, we particularly included only studies that had study participants who were aged 18 years or older and who were noted to have a serious mental health illness. We operationalized SMI as defined by the NIMH, which you may see listed there, but essentially our boundary was they had to indicate that the condition had significant impact to daily functioning. The intervention, again, like I've said earlier, that we looked at was interventions who are intentionally providing peer support, and that the provider was a peer volunteer or worker in an outpatient setting, and that peer support had to be the primary means of delivering the intervention. For studies that we excluded studies where the effect of peer support could not be isolated from other interventions, and additionally, programs that were solely in residential or inpatient settings. In this graphic here, you see the various categories we had for the data that we extracted, aggregated, and synthesized. In regards to the who, we were really interested in who is the peer support worker, how are they trained, and what are the demographics of those people? And additionally, who are the people receiving peer support, and what is the representation, particularly for underrepresented communities in the samples that are being targeted? For the what, and really the heart of our research was what competencies are being trained, and how are they being trained, and how are they defining those competencies? And we separated that both into peer support and clinical competencies. And in a moment, I'll get into the taxonomy we utilized for that. We also looked at, are there any formal practices or adaptations that they use for inspiration? Are there existing peer support practices that they took either components of or retaught entirely? And lastly, were the peers themselves supervised, and what training was involved in the certification? Was there examination? Was there supervised work hours required, etc.? For the where, we were focused on the trial setting, the type of setting, so rural or urban settings, and the trial modality, so were these interventions delivered asynchronously, synchronously, online, in person, hybrid, etc. And as for the how, again, we looked for multiple different variables relating to training and supervision, including the length, the modality, etc., the delivery and format, and additional items such as compensation and the status of certification. In regards to the competency taxonomy, I want to point out I have printed cute little handouts for you all to look at. This is a brief summary of our code book. I want to emphasize this is not the thorough, fully detailed code book that we utilized for our competency taxonomy, but we split it into two categories of peer support competencies. The peer support competency taxonomy was derived from the official guidelines by SAMHSA, and the reasoning for that was, for the US at the very least, you are required to train those 12 competencies in order to become a certification entity. And so we utilized their definition and their examples as a means of coding our data as reported throughout the literature. In terms of clinical competencies, we identified 5 common categories that tended to come up across the 43 studies. And that was first and foremost, mental health diagnosis and psychoeducation, CBT techniques, basic counseling skills, case management, and then ACT. Again, you are welcome to go to the conferences on your own time, but just to write a brief overview of at least 1 or 2 of them, the one I want to point attention to is sharing lived experience, and that there are varying definitions of even what lived experience means, and through SAMHSA, they really emphasize the skill of how do you speak on your recovery journey strategically to inspire hope, and when do you stop speaking to allow for active listening, and when to identify the peer skills. And during our Q&A, I'm happy to answer any more specific questions about specific competencies as well. In regards to our process and our method for identifying the articles included on our review, again, I won't go super in depth in this process, but essentially for screening, we had a group of 4 RAs, me and a fellow members of our lab for the screening process. And then for the full text screening, we also had additional colleagues from Sangha Health with a total of 7 people completing the data extraction, aggregation, and synthesis portion. By the end of our identification and screening process, we found a total of 43 articles. The source of those 43 being, 1, the most recent systematic umbrella review, which was conducted in 2023. And for that systematic review, we recognize that their timeline only went up to September of 2020 when identifying articles. So to compensate for 2020 to 2020, at the start of the systematic review was October 2023. We used these additional databases listed here to identify articles within those 3 years. So before getting into the results section, I want to just first emphasize a common challenge we experienced in this systematic review was the lack of reporting from many of these articles. As you will notice, many of the variables we looked for either had a limited number of studies reported, and thus that will be reflected in the N included, or you will see a complete lack of that data reported purely because little to none of the literature included reported on those variables. I first want to begin by discussing the trial characteristics. So what was the infrastructure of the 43 trials conducted? The average sample size across 43 trials was around 226 participants, the lowest being 21, and the largest sample size being 1,827. A majority of control groups for these trials were treatment as usual, as compared to the 2 other most common occurring control groups, which was positive controls. So comparing peer support to other forms of clinical interventions that were being investigated, and a waitlist condition. A vast majority of interventions were delivered in person. However, only 37 studies explicitly stated the modality of their trial. And of the 14 studies that specifically explicitly stated whether they were in an urban or rural setting, only 1 study was in a rural setting. And what I want to further emphasize is even the study that had a rural setting included, they had a hybrid approach where they had multiple sites both in urban and rural settings. So this is a very large lack of rural representation among peer support trials. For the 40 studies that did provide information on the type of setting, we found that a vast majority of peer support intervention trials are being implemented in community settings This could be things like community mental health clinics or also community-specific resource centers that may not necessarily be mental health clinic spaces. The other two settings that, although not occurring as frequently, but were present, was outpatient settings and a couple of online settings. And online referred to both a few email thread versions of peer support, as well as online forum peer support groups. In regards to the sample demographics, as you will see in the end numbers again here, there was a vast lack of reporting, especially in regards to a couple of demographic data such as employment and education. So of the studies that did report education, a little more than half of participants, the maximum education they received was high school or less. In regards to gender, around nearly 58% of participants were female, and 41 studies provided information. I also wanted to point out that of all 43 trials, only 3 studies asked for non-gender conforming identifying individuals, and only 3 participants indicated they were trans or non-gender conforming. And then the additional demographic is around employment. A vast majority of the participants in the studies that did report employment status, a vast majority of them were unemployed. In regards to the location of trial, you can see here that the trend here is many of these trials are being conducted in high income settings. And a vast majority of the trials included in our study that we identified from both the umbrella review and the databases were primarily within the US. This table here describes the breakdown of formal diagnosis data for the samples across all 43 trials. So the N here again refers to the number of studies that did provide formal diagnosis data. There were some studies that did specify their participants were either diagnosed or that they were experiencing the different categories of conditions we have listed here, but did not provide formal diagnosis data. The percent of sample diagnosed that you see on this column is the average rate of diagnosis for that particular condition across those studies. And then the range is the min and max rate of diagnosis across those studies that did include that formal diagnosis. As you can see on the table, the most commonly occurring diagnoses that did occur was for both bipolar and schizophrenia and other psychotic disorders. What I do want to also emphasize is that for a couple of these studies, they had multiple different diagnostic criteria. So one study may have included both bipolar disorder and depression and anxiety, whereas some studies were only focused on one condition, which is why you may see a bit of overlap. Now going into the characteristics of the intervention and what practices are being implemented across peer support trials, we found that the average number of peer supporters used within a single trial was around 10 peer supporters. And for the studies that did report whether they were adapted or structured, only a little less than 50% actually indicated using or adapting a pre-existing peer support intervention. So a good decent amount of studies are creating in-house trainings. For interventions in terms of modality, nearly half of all interventions were one-on-one meetings, where compared to other interventions which may have been group settings, or for our online ones specifically, there were group online forums or email threads, or even like micro groups where you were paired with a couple of other people. The average duration of a single session for peer support was 105 minutes. And I want to also note that only 21 studies provided the information of session duration. What I also found very interesting was in regards to stakeholder involvement, only 12 studies indicated who was involved in the formation of these interventions. And as you can see here, only 4 of those 12 studies directly involved lived experience expertise. In regards to combination, which 7 of the 12 studies included, that was a combination of the research staff, clinicians, and peer support workers. So you do see, at least in those 7, a co-creation model being developed. The specific practices for that co-creation were not specified though within the research. This slide here breaks down some of the general trends in training and supervision. And what I want to emphasize here is this was not the only variables we looked for. We looked for many more variables around modality, around how are you training to become a supervisor, and many more variables that were completely missing from the literature, and maybe only 1 or 2 studies included as well. In regards to training, for the 14 studies that reported it, we found that nearly 60% of trainers were peer support workers themselves. So they had more senior peer support workers with experience providing support to more novel trainees. A quarter of trainings were conducted in person for the 12 that did report that information. And like I mentioned earlier, Nearly a little less than half of studies used in adaptation or based their intervention on a pre-existing peer support intervention. Of, excuse me, of the 20 that did indicate that, nearly a quarter of that intervention was RAP, which is the Wellness Recovery Action Plan, which really emphasizes that practice of creating mutually established goals and working to obtain and achieve those goals. In regards to supervision, for the 17 studies that indicated supervision at all, 41% of the supervisors were peer support workers. The majority of supervisors were clinicians or research staff themselves, which contradicts with the recommendations from the federal guidelines. We found that supervision was, for 42%, was implemented in person. The other two common modalities was an online version, and usually that was because the study itself was being conducted online. Or there were asynchronous forms of supervision, for example, a checklist where they would review it together, review after each session to see, did you complete every task that you were supposed to? And lastly, for the modality of supervision, 40% of those trials implemented a group supervision model, as opposed to, again, that checklist asynchronous model or a individual model. So this graph here is really the heart of our research, and I will spend a bit of time describing what you see here. On the very far left column, you see each of the competencies from our competency taxonomy. On the bottom, it is the frequency from 0 to 100%. So what was the frequency of a competency being trained and implemented? And on the top, as we see here, this where the category is created. So the very first column being across all trials, what was the frequency of XYZ competency? And for the other 4 columns, it was our 4 categories of SMI, which is again schizophrenia and other psychotic disorders, depression, bipolar, and anxiety. Highlighted in yellow is the most commonly occurring competency across both peer support competencies and clinical competencies. As you can see in our results, collaboration and care was the most frequently taught competency across all trials. And for the clinical competency, mental health diagnosis and psychoeducation across all trials, and even for data synthesis per condition type, mental health diagnosis and psychoeducation was the most commonly occurring. For schizophrenia, depression, and bipolar disorders, providing support was the most commonly taught competency. What I want to also point attention to is that, particularly for shared lived experience, despite being the core of peer support, a little less than half of all trials formally trained their peer support workers on how do you share your lived experience. Now moving on to our discussion, again, you see the all trials graph to the left. Some trends that I pointed out in my conversations with just people in the peer support field and within our lab, some insights we had was that collaboration and care and providing support being consistently the most taught does point to the same values of peer support around mutuality, goal setting, etc. What I also want to emphasize is, and a limitation that I'll emphasize later on, is provide support is a very ambiguous report of a competency. And you do see across many trials that they do use this exact same language without specifying the exact practice of what does provide support manifest for this trial versus that trial. Some skills that did come up in our research that we associated with both of these categories was things such as active listening, mutuality, identifying the needs of the peer, etc. Like I mentioned earlier, a common and the most shocking gap we found was just the vast lack of formal teaching on how shared lived experience is not consistently taught. One attribute that we considered was the variance in definitions of lived experience, and perhaps the assumption that because they have already undergone that recovery, perhaps they have the lived experience, they already know how to speak on it, versus receiving that formal training. And that does bring a lot of concern around liability for myself, as well as my conversations with other people who are formal trainers, is that in the peer support realm, you do see a lot of conversation around, we need to train peers on how to talk about their story, because it's not only a storytelling skill, but it is also a form of ensuring liability, as there are concerns around strategic disclosure, making sure a peer is talking about their story to inspire hope, versus potentially accidentally slipping into trauma dumping or potentially accidentally re-traumatizing the peer that they are supporting. So that's something in our own curriculum we will have to highly consider as we consider those boundaries. And lastly, and not shocking, but I feel like it does reflect a lot of gaps in the peer support field today, is there is so little training around growth and development. So growth and development training refers to how can the peer leverage their expertise and their experience to advance their career, advance their income, and become even more involved in more leadership roles in peer support. And only 12% of those 43 trials had that formal training. And a common barrier cited in the peer realm today is around compensation, around supervision, how I become a supervisor, and lastly, how do I leverage my peer role in a lot of this infrastructure that may not have ever had peer supporters in the first place. In regards to the clinical competencies, mental health diagnosis and psychoeducation was the most frequent. And we did see at times overlap between mental health diagnosis and the competency of providing support. And that is because there is overlap around skills such as active listening. And the other skill that most commonly came up for this category was, how do I understand my diagnosis? What does a diagnosis mean? What is the criteria for the diagnosis? And more broadly, what does my condition mean for me? And does that validate the experiences I'm experiencing? And if not, what is not part of the quote unquote symptomology that I'm also experiencing? In regards to study limitations, like I mentioned earlier, there were multiple variables that we did seek to identify, and they were just not recorded across the literature. In regards to the WHO, only 5 of 43 studies provided any information, either descriptive or formal diagnosis data, on what was the illness experience or the lived experience from the peer supporter themselves. They just broadly said they have lived experience without any context of, was it lived experience recovering from major depression, or was it lived experience recovering from PTSD or any other condition? There were 0 studies particularly looking at the impact of peer support on young people, elderly people, and BIPOC communities, despite, again, peer support really coming out of those very communities, trying to form support groups with one another, first informally, and in recent years, more formally. Diagnosis itself, as you all noticed in even the reporting of that data, a little less than half of all trials provided formal diagnosis data, bringing the question of how did you measure someone was severely mentally ill versus moderately? And so that does bring skepticism to the literature. And what I also wanted to emphasize was peer support is not a purely diagnostic targeting model. A lot of the issues that come up in peer support is very intersectional, and it comes around the issues of, I don't have housing, I don't have food, I don't know how I'm going to get to my appointments, I have a doctor, but it takes me an hour or so to even get there via public transit, or even more. And yeah, in the reporting of sample demographics and other moderators, there's nearly little to none on how did those factors further impact, one, the impact of peer support on the interventions, and two, the intersection of that with their diagnosis status in the first place. In regards to the what, as you all will see, we did not conduct a meta-analysis for our outcome data. That is because, one, to stay true to our protocol, and two, just recently out of King's College London, they also published a meta-analysis of peer support intervention very similar to our own criteria. But also there was intense heterogeneity. When we were looking at what outcomes are being reported, there was over, I believe, nearly 300 different measurement tools across all 43 trials. And so it was difficult to assess trends within those outcome data. And additionally, the training content, a common comment received around even our own taxonomy was the ambiguity of the content categories. And that speaks to the same ambiguity in which training is being referred to in the literature and even out of SAMHSA itself. And also additionally with certification, only 8 of the 43 studies mentioned certification. And even of those 8 that mentioned, none of them mentioned what criteria was met, what supervised work hour experiences was required, what written examination was required. And so there is a gap in that literature. In regards to the setting, like I mentioned earlier, only 1 trial was conducted within a rural setting, and that was a multi-site model. And only 3 were conducted in lower middle income settings, despite peer support, evidently, as we see in the Global Mental Peer Network, it's evidently being implemented across multiple different global contexts. And yet the literature doesn't reflect that. And in regards to the how, only 16 articles indicated supervision practices. And so for the remainder of studies, there was very little to none reporting on, again, how was the supervisor made? Did they train in-house or did they train from a third-party entity? And even if they didn't report it, the supervision wasn't specified at all. Like I mentioned earlier, there was little to no information on certification requirements. And lastly, the length of the training. There was, I would say, roughly a little less than half of trials reported on the length. However, the way in which they reported wasn't consistent. For example, some trainings said it was 3 months versus one training would say it was a 2-day training, but is it 4 hours both days or is it 8 hours both days, which is a judgment we cannot make. So some of the suggestions we have for future research is one, clearly defining what the author's perception of lived experience expertise means, as lived experience can either be limited to formal diagnosis and being a consumer of mental health services, or more broadly experiencing this illness, as well as having extended criteria for reporting demographic information and going beyond the norm of just race, gender, SES, etc., to really capture the same variables that peer support tends to address, again, such as your basic needs. There is definitely a need to increase the number of trials in underrepresented settings. In the peer realm, there has been a lot of discussions around youth specialization because there is definitely a need for youth mental health interventions. And yet in the the trial literature, there is a clear gap of that, additionally as well for BIPOC and elderly communities. And lastly, to address the huge gap that we kept running into, there is a need for the literature to be more detailed in the way that they report their training and certification, be it supplementally, including a training manual even would have been helpful. But again, because of the minimum reporting of content, the certification requirements, and the practices, it was difficult to even aggregate that data. So in regards to what we've learned for our intervention and for next steps, what I have constantly preached to people who have asked me in the last month, so you finished it, what did you learn? And what I've personally learned is the literature does not completely understand peer support, and academia has, I think, a lot of work to fully capture what does it mean to be a peer. And so what our lab will be doing is conducting survey and focus group discussions, as well as key informant interviews with peer support experts globally to really capture that more personal lived experience and to ask about those gaps around what was your training, how did you receive it, those logistics around what was the length, et cetera, and more additionally, what were the challenges to your training? What did you learn that was within your training, and what skills do you use that wasn't in your training, but you apply to your everyday role as a peer supporter? And so we're hoping with this data collection methods that we'll be able to fill in a couple of those gaps within the systematic review. Oh, there you go. So I want to acknowledge that this has taken a very large team of supporters who I will call my besties. I have a lot of love, humility, and gratitude to many of you for supporting this research and really helping me dive into my passion for peer support. I also want to shout out my wonderful peer supporter who I have at home, basically attached to the hip every day. So that is all for me. I am always happy to answer a ton of very specific questions about data that was not included in this this presentation. Following the presentation, my hope is that through this presentation and y'all's questions, I know what to emphasize for our manuscript and any additional insights that you all hope to see. But I've also left a few questions for you all just to ponder on as you either formulate questions for me, unless you already have some for me. But otherwise, there's my email and my LinkedIn. Then you all are more than welcome to email and message me for additional conversations or questions. But thank you all for your time and your support.
So, questions for Isaac? Or any comments or suggestions? Goodness, this is a very quiet group.
Yeah.
Okay, thank you, Krishna.
Thanks a lot, Isaac. That was a very interesting presentation. I appreciate you going into depth of a few aspects, and it was interesting to see how people have represented it, different pieces, and missed out on some aspects as well while they have formulated curriculum and also overall guidelines. I'd like to ask from your own experience, because you've done the whole peer support training, you've been one who's taken that role on. While you went through this research, did you identify something that came across as a shock or a surprise to you? Because you've done the training yourself, you've provided support as well, and you were like, this is pretty surprising that literature says this, as opposed to, let's say, what you've done.
Yeah, I think two immediate thoughts come up. The first one is, again, that statistic of the lack of formal training around lived experience. I myself, in my own training, I felt I had lackluster experience on, we had a little storytelling activity, and that was a quick 30-minute activity, and that was it. But even in the literature, it's shocking to see there's an assumption that you went through it, so you obviously know what it feels like, but that generalization can be dangerous, especially when you consider different populations. For example, being a Mexican American living with my mental health challenges is vastly different from that of other populations. And so there is a need for formal training around storytelling and how to share lived experience strategically. I think the second thing was the very large lack of advocacy training. Like I mentioned, and I didn't have time to include it in this presentation, but peer support has a very rich history of political resistance and resisting medicalization as a means of oppression. And yet you don't see that advocacy training and really that human rights centeredness reflected in the training curriculums implemented across all trials, or really even in the landscape, which even in my own training, I was disappointed I didn't receive much training from that program for advocacy. And like I learned that through my own lived experience being, from an underrepresented community. But even across trainings I continue to look at, many of them lack that particular component, despite that being really the inception of this field to begin with.
Yeah, makes sense. Thanks a lot.
Laura?
I'm curious if you noted any differences between how training supervision were reported in the landscape review, or even just from your own experience working as a peer supervisor, what you know about training supervision and what you saw in the peer reviewed literature from doing the systematic review.
Yeah, so I'm personally not formally trained in supervision. That is something that my home state, or at least my county, didn't have, but that's something I'm still seeking. But in regards to the landscape, I am a huge fan of the NAPS document because, again, NAPS is comprised of peers from around the world, or around the US, sorry. And that particular document reflects very specific practices. For example, even when they talk about peer supervision, the first thing they say is a supervisor is basically a mentor. Your job is, you have been in peer support longer, help your newer peer supporter navigate challenges that you may have experienced. For example, the most common one that I constantly think about that was in my experience was how do you set boundaries so that you don't become re-traumatized? And there was a heavy emphasis on deconstruction of power dynamics. The literature doesn't really touch on that at all. They just mention we had peers as supervisors, and there was little to no mention in the literature of what was the training for supervision, what was the criteria to be a supervisor, and more often than not, the default was it was the researchers or the clinicians associated with that trial supervising that study, which included supervising the peers delivering the service. So I felt like there was definitely a disconnect from what NAPS and the federal guidelines state for supervision, given that document came out just in the last 2 years, and these trials have are much before that as well. But that definitely was not represented within the literature.
Yeah, really, really impressive. Great presentation. I've been following this on all our meetings for weeks, so I'm pretty aware of where it is, but it's nice to see this as a presentation, to see it come together this way. So I think you're highlighting some really fascinating limitations with peer support, and I think that there are some challenges with the formalized curriculums that are being used, and I know that those sometimes go against some of the actual peer support models. So I think that what you're highlighting, I think, is really fascinating to inform the curriculum that you're developing. Just a couple of thoughts. One, I'd be very curious about who funded the different studies you found. So I'm wondering if that could be one more variable in your sort of data table. And who are the funders? Are these NIH? Are these SAMHSA? Are these who are they community foundations? Philanthropists? I'm just be really curious. Sometimes they disclose that, so just out of curiosity. Or is this industry funded? You might be surprised. There might be some actually that are. So I'd be curious about that. The lack of so the second point is the lack of global studies. I wonder, is that because you restrict it to RCTs? Because there are some studies that have been conducted in other countries, and I can think of one program in particular, the Upsides program that Sumitra Pathare is part of, and there's a few others, and it's actually it's like a consortium of at least 6 or 7 countries, and many of them are LMICs. So that may be worth looking at, but it's not an RCT, so that maybe is why it didn't get captured in your search. I think the other thing too is, have you looked at the clubhouse model? There's a lot of papers on that as well, and I'm thinking that's in 50 some odd countries at least. So I think that again, that spans some of these lower resource settings that and they also practice their own version of peer support. Maybe worthwhile looking at. It may not fit into your review, but it might be something to include in your discussion, that it didn't show up because they haven't been evaluated in RCTs, for instance.
Yeah,
but that might be something just to think about.
thankfully, one of our EAG members is affiliated with Fountain House, and they're used to the Clubhouse model. So I'm hoping through our key informant interviews with them that we'll be able to get insights a bit more about that. But thank you for your suggestions. I'll definitely go back and look around the funder one. Top of my head, I feel like many of them didn't disclose if there was any industry interest or such, but definitely something worth going.
It should be in the acknowledgement section of the papers, not in the actual text.
So we have-
For the landscape review that your folks are doing in India, though, with Sangath, would they capture some of what John is mentioning with low and middle income countries?
The hope is to do that, do their scoping review. Their scoping review, to my knowledge, off the top of my head, is not limited to just RCTs. I will say, even in our study, we did come across additional trials in India and in China and in other additional contexts, but they were not trials. So they were inevitably excluded. So I'm hoping with their broader scoping review, maybe it will capture some of those lower middle income country
Yeah,
perspectives.
so I was thinking, the studies I'm familiar with, they're somewhere in the Middle East, somewhere in South Asia, they've all been, they're not RCTs.
So I've got two hands, and then I think we're gonna have to take a move on to the next presentation.
Yeah, hi, thank you so much. I really loved learning about this. A lot of my work has looked at peer support like in vivo in school context and adolescence. So I'm really interested in like youth peer support, and I know you mentioned that as like one of the limitations. But something that I've been thinking about, and I'd be curious to hear your thoughts, is like, are there ethical concerns specifically when we're working with youth to like put this responsibility on them to be like peer supporters?
So I have the institutionally correct answer, and then I have my personal experience as a
Yeah.
youth. So the institutionally correct answer in the typical, especially in school settings, the reaction that I got a lot as somebody who was seeking to get involved in that work
Yeah,
was youth can be a liability and students can be a liability to one another. And so institutions are hesitant to provide that agency. What I always find very funny is, and I'll use Harvard as an example, Harvard has a peer counseling programs where students are being trained to become peer supporters essentially. And those programs are successful because there's a very clear triage process to refer students to formal counseling services. What I have asked across multiple different researchers who do work with youth peer support, my common question is, how do you overcome that argument of liability? And the one that always sticks out to me is, any provider can trigger a patient. I myself and I have had friends who have had not the best therapists, and they've told me my own therapist has triggered me. And the common argument for youth peer support, who people who are hesitant to take it on, the argument is, what if a youth triggers another youth? But I feel like our role being in these roles, I feel like a common advocacy that we can even do as a small step is just pointing out that's not unique to a youth providing peer support. And my own immersion into the peer support role myself was, I was informally doing peer support just by nature of the fact that I was mentoring students. And then all of a sudden I learned about formally providing peer support, and I went, oh, this is a model, and literally there are many youth like me doing this work, untrained and unsupervised. So
I think, thank you, I appreciate that. I think my question was not necessarily about liability and like what happens if the kids are wrong, but like, is it fair in a systemic sense to put the responsibility of like mental health care on youth, children, like youth? Because I'm interested, I'm working on like my training grant idea, and I'm really interested in like peer support in like middle school and high school contexts, but like they're kids, so is that fair?
Oh, I understand. So one program they mentioned to look into is in California, they recently launched their, it's out of the Children's Trust, and it is looking at training older age high schoolers to provide peer support to younger students. I think that in the peer support realm, there is very little, at least in the US context, I haven't seen much work around middle to high schoolers, but particularly at least university students, I don't think that it's unfair. And even high school, I don't think it's unfair. I'm sure that many of you see in the media, there are already informal peer support groups such as like forums on Reddit, like Discord chats, and people are finding, especially after COVID, finding forms of informal peer support digitally, for example. So
Gloria,
Thank you.
I think we'll
I
take
was gonna
just,
let, you can go, it's okay.
okay, Dayani?
Sure. Yeah, absolutely.
Yeah, I'll be very brief. Have you crossed by any study evaluating the cost effectiveness? Because you mentioned that it decreases psychotic symptoms, substance use, and even hospital admissions rates. So I was wondering if you found some strong evidence, or if you are thinking of doing some research in this sense, because then you could put a very strong case for policies and everything.
yeah, so at least in this study, we didn't look at evaluations of cost effectiveness, since we were interested in direct RCTs for peer support interventions. However, in the broader literature, there are definitely research around the cost effectiveness of peers, and that's definitely evident. That question, and the way that it's been, the narrative that's been used for that has been problematic at times, where some institutions have made the argument, a peer support worker, and I'm quoting, a peer support worker can do similar work to a case manager, for example, but with less the training and less the cost, which is a very dangerous argument, since that pushes this narrative of peer support is not its own specialization, but rather an alternative. Whereas many successful models rather treat it as a complement to other services. But there are definitely cost-effective studies, both here in the US as well as a couple from European contexts that support that notion.
Okay, well, thank you very much, Isaac. Before we move on to the next presentation, I just want to say that was one of the best presentations that I've seen in the
Okay.
lab. Yeah. It was really outstanding. Your presentation was terrific, your slides were great, and it was just an excellent presentation.
Thank you.
I just a few suggestions to you. I think it's helpful when you're updating a systematic review if you can distinguish what was already described from what has been added and present the totality. So I'm assuming these are the totality of papers and not just the new ones that were found. And if they are, okay, that's great. Secondly, it's very common when you do a systematic review not to have all the information you want from the papers. Typically, you would really contact the authors, and you would personalize, write to the authors and say, we want to include. I get this all the time. I would like to include your paper in a systematic review. Authors are usually very responsive because they get an extra citation for that paper. So they usually do respond to that. The question of the large missing chunks of the world, you need to acknowledge that the fact that you only included English papers. I don't know if that's correct. You only include English was the only language, right?
So there were 4 articles that were non-English, and one was in Spanish. Oh, no, sorry, all were in Chinese. But then even when we asked, at the time it was Mushi, that was RA, and she looked through them. She confirmed that they're not trials.
There were no Spanish or Portuguese or French papers.
Not French, I believe one Spanish, and then when Natalie looked at it, it was not a trial.
Okay, all right. So then it's okay, because I think a lot of Latin American papers, studies don't get published oftentimes in these, these journals, and you've got to make sure. Then you need to, then you can comfortably say that there were no papers from Latin America, but you've got to make sure that you have included Spanish in the screening process. Otherwise, there will be. And of course, Portuguese, let's not forget that as well.
We can help if you need help with that.
Yes, I know. That's why I said Portuguese, Spanish and Portuguese. Maybe you need to talk to Davide afterwards about the possibility of doing a components analysis. I don't think we should discuss that now, but I think the fact that you've done an extraction of all these data, at some point, I would recommend you meet with Davide, show him the data that you have, and see whether a components analysis, a network components analysis might be helpful, because as you remember, Davide is doing something not that different, but in the area of common mental disorders and task sharing. There may be some differences because the outcomes are so different in this area, but I'd recommend that you look at that, because that could help us understand which of these different components seem to be the ones that are most valued. One way of doing that is in the qualitative studies, because you present these components as well. I think it's a good idea, the focus groups, and say, this is what we found, and then have people actually comment on which of these components from their experience tend to be the ones that are most valuable in their interaction. But another way is statistically to look at whether you can determine which of these components has the largest effect on the outcome. But that depends very much on the type of data you have. And so, connect with Davide, and hopefully he can guide you in that. Thank you very much, Isaac. Well done.